David Maxwell Jolly, who was appointed Director of the California Department of Healthcare Services by Governor Arnold Schwarzenegger. Mr. Maxwell Jolly previously served as Director of Department of Child Support Services and Project Director of the state's Child Support Automation System.
Welcome. Thank you for coming, and please proceed with your testimony.
Good morning. It is still morning, right?
Yes, it is.
Yes, good. Pleasure to be here and have a chance to talk a little bit about home and community-based services and care in the long term. I've offered some testimony, which I'd like to provide a summary for, and then we can continue with some with your questions. I get it that you actually ask a lot of questions here, so I'm eager to hear your questions and your point of view. But I'd suggest what I tried to do in my testimony and my presentation was to step back a little bit from the current budget angst that we're all going through. These are very terrible times with respect to our revenues, and we are doing some very tough things in the state to try to survive, to get through. The Health and Human Services Agency and our program in Medi-Cal in particular have suffered some significant reductions. We put proposals on the table that are very, very difficult proposals, and at the same time, though, in the context of this budget problem, we've been trying to think about the long term. And last year, as part of the budget solution, we passed a bill that framed our efforts to work on the renewal of the 1115 waiver, which we have in place, that in its current form is largely focused on indigent care funding and hospital funding. We set our sights on applying for a much broader waiver, a waiver that would try to make more fundamental changes in the way we deliver services in the Medi-Cal program in a way that would help to slow the rate of growth in Medi-Cal, so that in a few years we'd be in a better position to be able to adjust to whatever sort of financial waves would be coming along to the state's shores. Integral in that proposal is the idea of providing more organized systems of care particularly in the program as it stands today, particularly targeted at seniors and persons with disabilities, who to a large degree are being served in the fee-for-service system and are not enrolled in our existing managed care plans. We believe that we can get a handle on the rate of growth of costs in the Medi-Cal program by providing more organized care for folks who are now in the fee-for-service system. And I think this is well in line with a lot of the themes that you'll see in the National Health Reform Bill that has passed, that there's a great effort and interest to try to find ways to consolidate payment for care, not on a piece-by-piece basis as the fee-for-service payment system does, but global payments for larger pieces of care. And the idea is that you give responsibility to an organization who knows how to deliver an organized care, and you give a larger payment covering a broad set of services, and it's that organization is responsible for getting the right mix of the delivery of the services on the ground to the person that are based upon their on-the-ground knowledge of the needs of that particular person. We've actually been successful in enrolling mainly our families in the Medicaid program, which we did in the 90s, in managed care, and we've shown some significant results in terms of avoiding unnecessary hospitalizations, slowing the rate of growth of costs, and we believe that the opportunities exist similarly for the aged seniors and persons with disabilities. There are other opportunities in the waiver that we're talking about, but I think that's fundamentally what we're trying to do in the first stage of this waiver. Now, in my testimony, I talk about the long and sad tale of trying to pursue home and community-based services and develop an organized system of long-term care. We have a wide variety of services, and I think the testimony you had before shows that California does invest a lot of money in home and community-based services in addition to long-term care institutional facilities. But it's hard to say that we really have a system of long-term care in place that really serves all of California. We probably don't really have a system in place in the Medicaid program that serves the Medicaid recipients who are my responsibility and our responsibility at healthcare services. Within the Medicaid program, we spend about $10 billion annually on long-term care services overall. About half of that is home and community-based services. And that's better than most states. So we have a lot of different kinds of services. We have direct service programs like adult day health care, in-home supportive services. We have services within the state that provide information and referral to try to get people to the right place to get the services that they need. We have managed care arrangements that are quite successful. The PACE program and in a number of manifestations throughout the state for targets frail elderly and at high risk of nursing home, and provide a broad set of services, including home and community-based services, as well as medical services in a complete package. We at the Department of Healthcare Services have a number of waivers that are targeted at some of those opportunities where we think you can get some trade-offs between institutional care and home care, where we try to make it so that we prevent people from going in an institution by supporting them through a waiver program in their homes or in assisted living facilities. Those programs are small, generally speaking, and they don't serve a lot of people, and they're fairly labor intensive. And they're also constrained by this issue of trying to make sure that they're cost neutral, that we want to make sure that that's the additional home and community-based services we're providing for the person who's otherwise in the institution, would otherwise be in an institution, don't cost more overall in delivering care that way than the institutional care would. It's difficult to monitor that to make sure that financial trade-off happens, because there are a lot of people who are kind of worried about the woodwork effect. This question of if you open up services, home and community-based services, there are a lot of people who will avail themselves of it even though they are not in a position where they're really at risk of nursing home care, or for the lack of those particular services, those particular individuals would go into long-term care.
Yeah,
yes.
Go ahead.
I want to spend a little time with that 1115 waiver. You're leaving the program waiver you had before and trying to either expand it or change it. I'm not sure which one.
Let's say we're growing it. We are going to continue to have components of the waiver which will request significant additional federal funding to support hospital care, indigent care. We're hoping to actually have a significant growth in what we call our coverage initiatives, which are providing medical services for indigents in the county level. But in addition to those features, which are really kind of the features of the existing program, we're also proposing to include under the waiver these new organizational approaches.
Which is managed care, right?
It will be managed care, and we're also allowing counties to establish an alternative to existing managed care structures to the extent that there's a need in the county to provide that kind of alternative.
What do you think the benefits of that approach versus your fee-for-service approach would be?
I believe that the fee-for-service approach in California puts the client in the position of having to put together the care that they need. They've got to find the physicians. They've got to find the specialists. They've got to find the institution. They've got to put the care together. They have to assess their own needs and try to figure out how to match the service array that's in the community with their needs. I believe in a well-run managed care organization, and I think we have quite a number in California who are serving our Medi-Cal clients. That organization, because they're at risk and has a commitment in making sure that care is provided within the resources that are available, they have an obligation to make sure that there are enough providers signed up for that program so that people can find a provider to meet their needs, that there's an assignment to a regular primary care provider, that there's case management and care management that is in place to try to identify people with high care needs, identify high users, and to make interventions so that you're getting people to get the care that they need.
Do you see this managed care function, the they call it case management function, do you see that equally dealing with the client's social needs versus their medical needs, or because it's in a managed care program, the medical will override the social need?
We've talked about this before.
They haven't heard this
discussion. Our institutions are healthcare institutions, and when they're serving clients, they're going to use medical models, and they're likely going to interpret issues as medical issues, and so they're less likely to provide a social analysis of and less likely to reach out for social supports and diagnose social problems. We've been urged a lot by folks. We've had an extensive stakeholder process in developing the waiver, and one of the things we're often urged to include in consideration is the questions about housing. And they are not the traditional sphere of concern of the Medi-Cal program, and yet there are the same kind of cost-effectiveness arguments you can make, and you heard a little bit of that today here about how critical housing is to provide a stable home for individuals. You can't treat health problems, for a person who's homeless as well as you can for a person who has, a stable housing and food on the table.
Can I come in and ask a question? This may sound very elementary and basic. Are you in the health providing business, or are you in the reasonable accommodation integrated into the community business? How do you view yourself in your job? Because we heard this morning a tension between the two.
Yes. I think that the Medi-Cal program is in the business of providing the health care needs of the beneficiaries. In many cases, the health care needs of the beneficiaries include, we're supporting in the long run people who are who need to have medical and supports to keep them functioning, keep them healthy, keep them operating. We make an effort to try to provide an array of services within the benefit structures that we have that will advance those aims. I don't think we analyze the issue of our delivery in terms of a reasonable accommodation analysis. I mean, our job is to meet the medical needs of our clients.
But just to take that one step further, would your view of accommodating medical needs also subsume retrofitting homes to be able to facilitate an elderly person's access to kitchen, bathroom, and other facilities so she or he doesn't injure themselves? Is that part of what you're being told has to happen, or that there's that pressure for that kind of access within the home if the direction is to try to keep somebody at home?
I think this gets back to the question of that I tried to address in the testimony, and it's that I think we, at the state level, are ill-equipped to operate a system of care delivery that would include all of those things and benefits and make all of those decisions about the trade-offs about whether this is an essential thing that's necessary for this person to be healthy and well, and whether it makes good budgetary sense to make that investment. What I argue in my testimony is that the best way to manage that kind of delivery of the care, to making sure that you're assessing needs and delivering in an effective and efficient way for the needs of the client. The best way to do that is to delegate that responsibility to a local organization that has an understanding of local resources, has an understanding of the consequences of action and inaction within a particular benefit, and has a financial stake in getting the right trade-offs among the services. For example, take a world where you provide a monthly or capitation rate for an individual who's enrolled in a managed care organization, and that capitation rate.
What is a cap?
Monthly membership fee, or it's a monthly payment we make to a plan. Say, okay, you promise to provide for the medical needs of this client, and if that monthly payment included what we think is going to be the actuarial costs of nursing home care and of maybe in-home supportive services and other services, as well as the regular medical services that be necessary to meet the needs of that population. Then we delegate to that organization the trade-offs between the modalities of what. Now, I could imagine in that situation that it might be an economically sensible thing for that organization to agree to put a ramp in a home for somebody if they based on their knowledge of that individual's particular situation, found out that was the barrier that they faced in keeping this person out, getting this person out of a nursing home or keeping them in their home. So I think that rather than a system where we say, Medi-Cal benefit is now building ramps in homes, I think if we delegate the responsibility for taking care of the broad needs for a clientele within the scope of the Medi-Cal benefits, there may well be times when it makes good economic sense to provide that kind of stuff.
Would Medi-Cal pay for a ramp? Would it pay to retrofit a bathroom? Would it pay to have what other changes in the home environment are necessary in order to keep that person? Where's the money going to come from? Keep that person out of the nursing home. So if the money's not coming from you or from whatever monies you draw on, right?
If we, what I imagine is a world where, okay.
I just want to know where the money's coming from.
Well, the money could well come from the pool of money we're now spending in a less efficient and cost-effective way. I think that to the extent that we are unnecessarily institutionalizing individuals, we may be spending more than we need to do. We may, if people stay in the hospital longer than they need to, if we figured out a way to get somebody out of the hospital, we'll probably save some money, and that might be where some of the money could come from.
David, let me, to both Davids, let me kind of give some help here. One of the things that Kay and I were talking about was sort of pushing this on a medical model, and me wanting to have a nursing home not be the criteria which we were against. At a county level, it is possible that you have housing money, which comes from HUD, to do this. I mean, so you've got a smorgasbord of places that you can pull if you don't have an isolated system. And my concern about
the silos, right,
is that it's always been an isolated. Well, it didn't start out being an isolated system, and it didn't start out getting Medicaid money. It started out in Title 20, so it could move around for its needs.
And that's the point I'm driving at. I'm not trying to make it score a debating point on where the money's coming from. I'm trying to understand, for what I've just described, the kinds of retrofitting that are necessary in order to avoid somebody from having to go in a nursing home, that the Medi-Cal is an appropriate source for that.
But the problem we have is remember, and this is a concern. When we did the report on Medi-Cal a couple of years ago, what we talked about was you have a system that's growing at a rapid rate that we can't sustain. So I'll remember this clearly, that someone starts out in the Medi-Cal system and they are diabetic. Their situation worsens. They're on Medi-Cal. They then become an amputee. Their expectation is, and this is where we get back into this, the planning of this system and what we're looking long term is, there's going to be an expectation that I'm on Medi-Cal. The state is providing me with my health services. I'm now an amputee. So now when you get into this question of what happens to that person and the level of support they need, are they going to an institution? Are they going to get in-home supportive services? How do you accommodate their life? Can someone make the argument who's been on Medi-Cal for 15, 20 years that, I am your responsibility, the state's responsibility, and it is your responsibility to take care of and provide and provide that ramp. And, going back to what Commissioner Anderson said, so that, the silos, ultimately, no one has a system in place at the local level that clearly spells out this roadmap that says, all right, this is where we're going to put you. The state has told us what your needs are. We have a designated, location or facility, or we have a designated system that pulls everything together with all the money. And I become more and more concerned about. You just asked the basic question: is it the expectation of are you in the medical services or are you in the accommodation of life services? I think they're becoming blended at a rapid rate because
it's in fact what we recommended in our social services report 4 years ago, that was the correct model for providing an array of services.
Could I offer? Could I have an observation?
Yeah, let me let Commissioner Shapiro, and then we'll turn it back to the witness.
Just very briefly, I guess maybe Mr. Carlson is the right person to ask this question to, but I didn't know to ask this question when he was here, so now I'll ask it of you, even though he should probably answer it. But in your example of the amputee, what is the state's obligation under Olmsted currently in terms of what the expectation of the amputee is and who decides and what is the standard at this point? That's where
and that's the big question. Is the amputee's going to make the argument, I've been under the state's care throughout my, again, started as childhood obesity, diabetic, now an amputee.
Okay, let's let Mr. Jolly take a crack at if he can sort of sort that out for us.
Well, it's hard for me to kind of understand how to deal with that particular situation. We provide an array of services, and that individual who's an amputee who was unable to control his diabetes will. We provide to the extent that the benefits are available, what's necessary to support that individual, provide wheelchair, we'll see what happens with our current budgeting, but, beyond that, we'll support that individual and their medical needs, based upon the set of services that are available in the Medi-Cal program. We do provide an array of services that offer alternatives to individuals, between the choice of institutional settings and staying at home. I wanted to offer one of the models that is probably a successful model of mixing home and community-based services and institutional care is the regional center model and the developmentally disabled. And one of the key features about that program is that the well-run regional centers look very, very hard for community resources first as a way of delivering the needed supports for their clients, so that if transportation can be provided through local public transportation systems, then transportation through some sort of special regional center funded system would not be provided. So part of the idea of delegating responsibility to local organizations and having some care management locally is to be able to figure out, to have a local organization that knows what local resources are and that can call upon them as needed to make sure that you complement the package of services you have with other things that might be available in the community. We have an entitlement to services. As I understand and I really I hesitate to get into talking about Olmsted very much here because of it's being actively litigated. But as I understand Olmsted, pardon?
Go ahead.
But I think we have an obligation to make sure that the services that we offer are available for people, whether they're at home or whether they're in an institution, and we strive to do that as best we can. So, I think our obligation to the individual you describe is to make the services available that we cover.
Yeah, and like I said, I understand the litigation. My comment was the first speaker also was hesitant because of the situation. I'm just saying that I think that when I sit here and look at it from a simplistic perspective, I worry more and more about the direction we're moving, because we are going to be in just plain and simple, a medical and accommodation expectation. We're going to have that expectation of both as the system continues to get larger, as people retire, as people age, and again, I think that's the concern is that your job right now is supposed to be medical services, is my anticipation, but it has morphed into that and much more, and it's getting bigger. And so, where's the money come from? You asked the basic question: where's the money coming from today? That's a great question, but where's the money going to come from in the future? And because then you're going to get sued because you're going to be in a situation where you don't have enough money to provide for all the people that want both the medical and accommodation treatment, and you're going to get sued because you just have to tell people no. As you just said, I mean, at some point you have to build, 1,000 ramps, and you have enough money to build 500. So you'll get sued, and you'll be in violation of something else. It's a difficult position to be in.
I mean, you have to set up a system where you get some control over the total money that's spent, and I also believe that you need to set up a system where you give responsibility for providing a set of a benefit package, a healthcare benefit package to an organization that has the capability of doing that, and you monitor what they're doing and watch their quality carefully. But then you give them a budget constraint, and then you give them some freedom to operate within that budget constraint. Sure. And that's the best way to get the most cost-effective, the most out of your money. Now, if that money isn't enough to do what everybody, we as a society feel ought to be done, then we need to increase that amount of money. But unless we figure out ways to set up those kinds of budget constraints, we are gonna be lost.
Well, sure, but again, your comment, while it makes sense, if you listen to what we were told by the first speaker about the Olmstead Act and the discrimination against, you have all the ADA implications and the discrimination concept. You can say that you've got to work within our budget constraints, but ultimately you're setting yourself up for a discrimination suit, potentially. Because not everybody can fit within those budget constraints. Not everybody's going to get served, and their needs are met.
Within the 1115 waiver, is there statewide-ness?
Is that not true?
Is there a statewide-ness responsibility?
The 1115 waiver has the ability to waive statewide-ness so that we can deliver services not statewide.
Isn't that what you mentioned in the managed care field and the waivers? I mean, that strikes a chord with me that was something that we encouraged in our Medi-Cal report that we issued about three years ago. We had the federal, Western Regional Director and said they'd be very receptive to that sort of thing. So it sounds to me that pursuing that is sort of consistent with some of the things that this commission recommended several years ago.
I think it's something the administration has been trying to do for quite a while, and there was a lot of discussion about it about 5 years ago within the state in our Medi-Cal redesign efforts. I think there was an effort to try to. There is concern that the Medi-Cal managed care organizations that we have may not have the capacity to deal with the substantial needs of this population. And so we have been working, talking to stakeholders and trying to lay out a transition plan and a set of standards targeted at these particular beneficiaries to try to provide some assurances that we're going to make sure that these plans are capable of delivering. I think the plans themselves in the last 5 years have also done a lot to understand the needs of these categories of beneficiaries, and I think that they've made an effort to put an infrastructure in place. There are substantial voluntary enrollments for seniors and persons with disabilities in our managed care plans that are stable and long term, and people feel they get their.
Does that include like the group clinical model, which we heard a lot of testimony about a few years ago, where you could actually get diabetes treatment in a group clinical model from a clinician rather than from a doctor, and didn't have to treat every.
Well, didn't we have to change we needed to change the law, the rules and the laws on that.
Well, that's where the waivers were.
Was the where the waivers were? We heard testimony that said, I think it was one of the physicians said, look, I'd love to be able to see 30 patients in a group clinical discussion, but instead I only get reimbursed if I have a room, one at a time they come in, and that's a deterrent. That's a deterrent to having an overall positive impact on the lives of people who are diabetic.
Yeah, I'm not familiar with that point, but
Okay. You don't have the IHS department under you, so
we provide federal funding. As many,
so you're the conduit for the funding?
That's right. The Department of Healthcare Services manages federal funds for a number of programs that are operated and administered by other departments.
So to ask you questions about the operations of that department would be unproductive?
Probably would be, yes. It would. I mean,
Are you funding the data system that they're creating?
I think we probably are providing federal funds. You mean CMIPS 2?
I'm not sure what the name of it is.
Called
I just
CMIPS
asked about
2,
it earlier.
right.
So.
Yes, that is a data system that has been underdeveloped for quite a number of years, and it's desperately needed. And I provide an important new capabilities to understand what's going on in that program.
Well, I think they said 3 years was.
It's going live 3 years from now, or
No. I think the 3-year comment was respect to the data collection effort that is being conducted by UCSF to produce an integrated database for analysis on Medi-Cal beneficiaries and their use of home community-based services, other long-term care services.
Right.
I think that
You're talking about your Medi-Cal system that we also had talked about before.
Well, we have sponsored some basic data collection, data assembly,
Right.
some creating longitudinal databases for clients in the Medi-Cal program that'll be able to get a long-term picture of what exactly is the service utilization for these particular beneficiaries, and that's what we've been funding. That in addition to that, I do know that the Department of Social Services have been supporting the development of a new computer systems to support IHSS eligibility, billing, and assessments. So, and
You
that
better ask them the details of that.
that they would be happy to provide you information about that in detail.
Any other questions from the Commission? Appreciate you very much for coming today. Thank you. We have.
Oversaw the whole Cal Support Services integration of that data system.
Okay, we have our final witness, and Stuart, if you'd introduce her to us, please.
Hello. Our last witness will speak towards moving towards care in the long term. We have Brenda Primo, who is the chair of the state's Olmsted Advisory Committee, as well as director of the Western University Center for Disability Issues and Health Professions. Previously, Ms. Primo served as director of the Department of Rehabilitation under Governor Pete Wilson. Hello.
Welcome, and thank you for attending and sitting through our lengthy hearing today.
It's been very interesting. Is it on now? Yeah. I did not prepare testimony for you because my experience has been that at the end of a presentation, which is where I usually am, because my job is to put a face on the population we're talking about, I want to listen. I want to understand where you are, or whatever committee it is that I'm getting to listen to, and understand how to answer some of your questions. And today I want to begin with a few definitions and then talk about the system that is required to provide care in the long term. And you notice we reversed it, and thank you, David. The first time I said that, David wrote it down. If we begin to rethink how we define the populations to be served, our pre-assumptions about the populations to be served, and many of our stereotypes about the populations to be served, all of a sudden, our modeling will change. If we look at policy as long-term and not the budget crisis of the moment or the policy issue of the day, but rather how we're going to provide services which enable people, which can include ourselves, our families, people we know, being able to remain independent, productive individuals in the community, we will look at the situation much different than if we take a carve out of one service or one department and decide, oh, it's not working. Let's go back to throwing them in nursing homes. Let's talk about the system, and let's talk about what we mean by care in the long term. I want to begin first, excuse me, by helping about the confusion on Olmstead. Olmstead is a single decision. It was a court decision that then was administratively promulgated, but it was a specific decision. The decision does have long-term impacts for populations from 0 to however old we get, and we're going to get to be over 100. By the year 2050, centenarians will grow by 10%. So we're not going to be old in the short term anymore. We're going to be old in the long term, and there's going to be the old, and the oldest old. So there's going to be a whole different array of services that we have to think about in the long term. Olmstead doesn't just speak to the medical model. The cost in Olmstead does not only come from the medical model. Care from Olmstead comes from just as you don't pay the electricity company for your television, you don't pay the electric company for your car payment. There are systems that have been designed that need to be more integrated, that have been designed and used to be a little more integrated, that looked at different elements of our lives. Transportation. Accessible buses don't come out of healthcare. The lifts come out of the transportation budget. However, that makes me able to go to my doctor's appointment if I use a wheelchair, have a crutch or a cane or a walker. So Olmstead is contemplated not in terms of only health care, putting the ramp in the home of the individual. There are times that it might be cost effective to do that. And I have a great example. I can't say who it was or which of my clients it was. There was a 500-pound woman in a house. Every time the ambulance had to go get her, it cost that plan provider in excess of $2,000. They did the math and said, we're going to use some of our overhead and put a $500 ramp in that house out of concrete so we can get her out of there. Now she can go in a bariatric appropriate van that costs us $200. It was a purely cost response that they had, but it was appropriate. However, they didn't have to pay for it. If it was an integrated system, they would have went to special circumstances, and that's something that we need to look at as a policy in social services to see that those dollars are there when needed, and they could have had a ramp built. Under Olmstead, what we look at is the whole person. Prevention is part of health care, but we don't like to do or talk about prevention and disability a lot. Primary prevention is a high priority in Medi-Cal. Secondary prevention should be a high priority among people with disabilities. That man who got the amputation, probably as soon as he got diagnosed, if he had been getting good secondary care, he would have probably learned things he could do to control his diabetes, which would have reduced cost. In the fee-for-service system, that doesn't happen now hardly at all. But we also have other services, educational and employment. In Social Security, there's a provision about employment that says you can be on Medi-Cal and you can make more money or in your payment, up to in California around $40,000 if you're significantly disabled. And you can still retain Medi-Cal. However, you have to pay a piece of the action. You have to pay for the insurance. Now, if I'm employed, I'm paying back in taxes. That's part of Olmstead. So when we talk about Olmstead and community living, it is not only medical. It has to do with the whole array of services. So as planners in the legislature, as planners here, when we look at the decision about how we're going to provide care in the long term, it has to be all of the elements of care that we all need, all the elements of support services. We need streets, we need roads, we need transportation, we need access. So Olmstead is not a singular issue around health care. And if it's handled right, if we do the prevention, if we have the access to get to doctors in a timely manner, if we have doctors who are trained to deal with disability, developmental, mental health, traumatic brain injury, and dementia, we will have less of that because the other services, many of them can be paid through other avenues. One of the reasons that healthcare costs are so high is, as she mentioned, in-home supportive services was begun by a radical group of physically disabled people who were very bright and been universities and had jobs. One of them was a director of rehab, the other was the secretary of Health and Human Services in Washington, D.C. They were very bright. And they said, we need to be independent, and we want social services, okay? But we want to be able to do it on our own eventually. We need these things to support ourselves to get to the place we can hire the housekeeper and not have somebody else pay for them. And that's how it began. And then the state said, ooh, this is costing too much money, so we'll take Medi-Cal money and we'll put it in there. Now it became a medical model. So we created our own monster by how we created the financial decisions we made to create in-home supportive services and to allow it to grow. The decisions that were made, I think the reason the court did what it did, and this is my opinion, I'm not a lawyer, wasn't so much that you couldn't narrow the definition of in-home supportive services or any other set of services, because the law says equal to, not better than. It was because it was arbitrary. I believe that if somebody sat down and really looked at how they wanted to define the sets of services and the need for institutionalization in a very logical way, the court would not do it. I think it was because the way I read it, it was kind of arbitrary. We're going to take all these people from this part with no respect to understanding whether or not those individuals were going to be impacted. I believe the state could, if it went about it in a way that looked analytically at the sets of services. A quad needs a housekeeper. A low vision person doesn't. They can have an in-home support. They can have somebody come in, orientation person, and train them to clean their own house. It depends on what the person's disability is and what the functional limitations are, and that's one of the good things about it. But I think the decision was arbitrary, and I believe that's why the court did it. So the court decision, I think, isn't the end-all to lawsuits that all people get everything they want. I think the state didn't take the time to do the things it needed to do. Having kind of answered a little bit of some of your concerns, let me talk about accommodation. There is a need for accommodation in the healthcare system. There is not accommodation and then the community. Imagine yourself waking up at 8 o'clock in the morning to a severe earthquake, 7.0. Your streets are buckled, your electricity is off, you have no water, but you did emergency preparedness, so at least you have something in your home. All of you have done that, right?
Yes.
Of course. So you're
we
there.
We recommended it.
You can't go to work. You can't make an income. You depend on the government to come and bring things to you, which will be a week later at least. You are not productive. Accommodation is for people with disabilities that way every day. It's like you being in an earthquake. It isn't about health care and accommodation. If I am a quadriplegic and I roll into a doctor's office and that doctor needs to look at me and that table doesn't go down to 17 inches, one of three things will occur. The first is I won't be examined. I'm not getting equal care, and I may have a pressure sore, ending up in the hospital for 2 weeks, which costs you a whole lot of money. I may injure a staff person or two staff people who are going to transfer me, which causes workman's comp. Or they may attempt to examine me in the chair, but they can't really see the back of my backside, so I'm not going to find that pressure sore. If you have a table that goes down to 17 inches, even if I have to have assistance, it's slide assistance with good training. I get on the table. I get adequate health care. If I'm a woman in a wheelchair and I can't stand and can't get a mammogram, my cancer's caught later. Again, it's a higher cost in the hospital. So it's not about the disabled having accommodation. It's about thinking about how we have to provide adequate care to individuals, no matter who they are. Disabled, language, life, religion, beliefs, culture, so that they can in fact benefit from, participate in, and do what they need to do to comply. My favorite story about accommodation is small print. When I go into the pharmacy, they gave me I'm legally blind, so don't raise your hand. They give me an 8-point item in paper that tells me all the things that can happen to me when I'm going to take my meds. Well, I got that for years and never read it, obviously. So I learned my where I go get my drugs. They put an announcement up and said for those of our customers who could benefit, we now have a 14-point. Well, I ran straight back and asked for it. Put my name on the list, came back, got it, and went home and read it. And for the first time in my life, I actually read what could happen to me. And I called up a friend and said, I could die from this stuff. I never knew that. Accommodation doesn't increase dependence. It increases independence. And it isn't separate from what we do. It's an integrated part of assuring that whatever that person needs, and in the case of health care, it would be access to services. That ramp may not be the responsibility of health care, but it might be the responsibility of the transitional living center that says, we're going to take everybody except if you're in a wheelchair. We're not going to have wider doors and an accessible bathroom. But guess what? A lot of people who need transitional living use walkers, canes, and are in wheelchairs, so they should provide that accommodation. So what is care in the long term versus long-term care? when Social Security was created, the legislators who were creating it looked at the death rate of the time, looked at the age of the death rate, and said, it's no problem, 65, most people are going to be either close to death or dying. Well, that isn't true today. And although we have made adjustments, we're not at all towards those centenarians that may live to be 110. And when they created SSI, they said, if you're disabled, you cannot work, and if you cannot work, you're not disabled. This is a stereotype and an assumption based on what we believe as a society about disability. And so there were all these incentives that kept people from working. They couldn't make money, they couldn't have assets, they couldn't have accommodations. If they went to work, they lost everything. A person who's on attendant care who's a quadriplegic may pay as much as $30,000 a year for that attendant, and people who make enough can do that. But they may have to slide up there to that high-level position. Today we're beginning to change that, and we need to change how we think about long-term care. When I talk to plans, they think of long-term care as nursing homes. That's why the discussion comes up. They think of it, you go back to fee-for-service and we pay for all those nursing home costs, instead of thinking about options in the community. And those aren't just your home. That can be group homes that you choose to go into. That can be transitional living. That can be supportive living. That can be any kind of living that, and we've talked about co-ops in our community of folks with disabilities where we all share common things that we need. We're used to that. So when we think about the Olmsted or we think about community-based services, we have to think of the options. And they're not only medical. We work with the plans all the time, and what we say is you don't have to pay for it, but you should have a handshake with your Meals on Wheels folks, with your independent living folks, with the regional center folks. Sit down and proactively work out the plan for that patient so that you don't do a wonderful job clinically, get them all better, they go home and they're isolated. Make sure that that community handshake occurs so that it might be somebody else paying for it, but you and the patient have care plans in the long term. The baby, we talk about the broken healthcare system, and I say, well, really that isn't accurate. The reason that one of the reasons it costs so much is the success of the healthcare system. The babies we keep alive at a pound. The people in accidents that we keep alive who have died 5 years ago. Will we leave them with high rates of traumatic brain injury? The individuals that we keep alive with respiratory quadriplegia, the extension of chronic conditions such as Parkinson's and cerebral palsy, because we have a dedicated set of medical researchers and primary care and specialists who are great at emergency medicine and acute care, only to return it to return individuals to communities that don't yet have the second primary and secondary prevention, accessible to medical offices and equipment that allow that person to continue to live at a quality of life that made all that money that was spent to keep them alive worthwhile. That's the reason we have to change our thinking from long-term care to care in the long term, because we're all going to be there. By the age of 75, 75% of individuals will have activity limitations of hearing, walking, seeing, processing, memory, and more. Each of us will have to enter a system. And when we make this policy decisions, we want to think about what kind of a system do we want to enter, since I intend to live past the age of 75. I would like to offer you the opportunity to answer questions, but I want to encourage you to think of care in the long term not as a medical issue. Medical issues are more or less in a person's life depending on their disability. You can be a deaf athlete and not have a whole lot of medical issues, but you're on Medi-Cal. Or you can be a paraplegic, a young woman who has spinal bifida, who's a racer, and she has to have supplies, but she may not be sick. You may be a 60-year-old man who's still working, who has some issues, but he's not necessarily going to cost a lot in the medical system, but he may need other services to allow him to live independently in the community. And a lot of that will be technology in the next 10 years. We'll be saving money because technology will be doing things for us. Of course, we'll have to spend it on that. So those are some things that I want to get across. As I hear you talk about IHSS, that's a single piece. And it costs what it costs in part because it is out there floating independent of some of the supports that need to be there, including a system of care, of medical care, that folks will need less of the care that they get at the home because they're getting some of that more of the community, more accessibility, more subsidized housing, which comes from the Housing Authority, not from David. It comes from the Housing Authority. We as a state need to have a policy in our housing that looks at the subsidies for aging and looks at the subsidies for folks with physical disabilities who need both accessibility and they need cost access. And then we could be paying $209 a month because the sliding fee scale gets us there. But we have to think of the system as integrated and not only look at one area and say, cost too much, we can't do that. So basically that's my presentation, but I would like to, don't raise your hands, ask anyone if they have a question.
Commissioner Mitchell?
I appreciate your comments, and I do think that based on the hearing today, I think I think we would all agree that when we talk about the system, that there is an integration. If you look at two things that you said, one, on the prevention side, one of the things that we talked about in the Medi-Cal report was, the state needs to look closer at prevention. We talked about the Medi-Cal patient that starts out as a diabetic, that then, or starts out with obesity, then becomes a diabetic, and then ends up as, potentially as an amputee. Prevention, I think it's how we define prevention here when you talk in terms of accommodation. I think when we were talking about accommodation, I think what we were saying is that the state, has now moved into that blended system, and there is an expectation that it's not just enough to say, all right, you now are a part of IHSS, good luck. But again, there isn't the cost of building the system is extravagant. There doesn't seem to be a roadmap. There is, and I think that's the concern, is that there isn't a roadmap, and there's a huge cost that's standing there at the door now, waiting to get in. As you just said, people are living longer. We know that we have the largest segment of the population on the verge of retiring, and as they retire and get older, they will want these services. They will want this integration. Your housing comment is absolutely correct. We hear all the time there's money in Sacramento and there's money in the federal offices at the federal level for building senior housing. Well, but then ultimately, how you build housing that can accommodate realistically the senior that may occasionally need to enter into the nursing home system but come back to their own home and not say, well, look, they're going to be living on $209 because that's how they're going to keep their home. So I think I don't necessarily disagree with I don't disagree with what you had to say about we have to think about the long-term aspect of healthcare of this system, and that IHSS is one component. But it's the focus of this hearing because everything I've read is that again, the governor has made his budget proposal. All the testimony today says you have to push more people into IHSS. You have to reduce nursing, the nursing homes.
And I think that's a confusion because IHSS is only one small piece of this. And if we keep focusing on IHSS, we will not solve the problem. And if we keep focusing on what this governor is doing at this moment, we will never solve the problem. We have to look at IHSS, as I described it, could be looked at, and there could be reduction of cost, although I agree that $75,000 a year in a nursing home where you're in a bed and you're told when to get up, when to go to the bathroom, that's not a quality of life. It's not even something that the folks that I deal with want to think about, and I don't think you want to think about living there either. But the issue is you keep thinking about only IHSS without consideration for all of the other surrounding supports, including Department of Rehab, Department of Developmental Services, Department of Social Services, and the integration of the flows of funds, both federal and state, that become integrated towards in care in the long term. And that includes children, CCS, education. One of the things and I heard this, and I don't remember who said it, but somebody says, well, you're the state's responsibility, and they're going to tell you what to do, not me. I'm in control of my life. The state isn't going to tell me what to do, and if I'm an amputee, I want a prosthesis from my medical provider. I'll go somewhere else for my rehabilitation, and I'll take care of my own independent living. So part of this is to remember that people are in different places, and that we have to look at that and it's like a bell-shaped curve. You got folks out here, they're very bright, physically disabled, folks with chronic conditions who just take care of it, and folks over here who had 24-hour care, Alzheimer's, dementia, extreme traumatic head injury. Part of our system has to look at how we're going to measure those services and how we're going to do it. But if we stick with just IHSS, we'll never get to the goal. We have to look at care, and we have to look at all the elements of, I don't even like the word care, supports in the long term so that people, all of us, can continue to live in our community. And that means universal design. If we don't design steps into everything, we don't have to worry about ramps. If we make signs big enough, we don't have to worry about having people have to read it to us. If we design our electronic equipment so that somebody who's blind can have it read through the reader on the screen, we don't have to pay for a reader. How we think about supports in the long term determines how we provide costs. And the other issue is we invest in the education of our children. It's very important, and it's a big issue in California. We invest K through university. But here's a little subtlety. It costs money for special education. It costs money for in-home supportive services. We invest in industry, but it costs money to provide technology for folks with disabilities to become independent. What is the subtlety? If we think it's productive, we invest in it. If we think it's a waste, it costs money. I would assert to you that care in the long term is all of us at some point in our life, and that we are investing, which means long term, and considering a system in the long term that all of us, our children, our parents, our grandparents, will at some point have to deal with, whether it's like myself having to deal with my dad, or it's us ourselves, or it's that child that we have with a developmental disability. So as we design this system, and it can't be done in this budget year, and it can't be done on this moment, we have to consider this isn't them. They're in the lifetime of all of us, we will be impacted. It's us. It's us in some way. It's us in our constituency. It's us in our lives. So we need to take the cost part and start to look at how we look at investing in employment for folks with disabilities, how we invest in access for all of our citizens so that everybody can use it equally. We have to consider this as, the way I like to say it is, the diversity of living. It's just part of who human beings are, and when we separate and when we lower the value of the costs we have to put in, and we don't evaluate it like we do that investment, that is, we evaluate investments, we see where the costs and expenses are, but we know that $300,000 machine that's going to do the MRI is going to be worth it because we cure people, but because we can do a lot of people through them. We have to look at disability in the same way. People, there isn't them, there are people. Some are very, very productive. Some are not. But I know lots of people who aren't disabled who don't work and don't want to work. So I don't like to make the judgment about who will be productive and who won't, and what investments we need to make and what we don't. There's a gentleman who works in the state right now. He's limbless, and his parents left him at Rancho because they couldn't imagine having to take care of him all their lives. And he was adopted by a woman. He went to school. They offered him prosthesis. He turned them down. Didn't cost any money. He hated them. He went to high school. He went to college. He then got a job. He had lots of problems because Social Security didn't want to let him do that. But he did it. He needed a power chair that had specialized devices. Today he is a special assistant under the Secretary of the Emergency Services Department here in the state of California, and his name is Richard DeVilder, and he's building the plan for emergency preparedness for seniors and people with disabilities. We're not going to leave them to drown in their nursing homes because he knows what to do, and he's creating it. He was on Medi-Cal, and it cost a little bit of money. He had to have a kidney replaced, had taken out because he lost a kidney. And then they had to figure out how to take his blood pressure. That was a challenge, but we helped Kaiser. But he's a valuable contributor to what we do. He pays taxes. And so when we think about this, we have to think about both sides of the ledger. I think all fraud ought to be eliminated. I think the guy running for governor, who's now Attorney General, ought to take care of that. And I think he ought to lower the standards by which he sues. But that's not really the reason or excuse that we should use not to take care of, but provide resources and supports in the community to allow folks to reach their potential. But that means we can't just think of them as sick people who have medical services. We have to think of them as our community, who work, go to our churches, live in homes next to us, have children, work for maybe 60 years, become disabled, and now need the supports we're offering. And many, especially our senior population, are like that. They've already paid their taxes. They paid their Social Security that now is gone, and that now their kids have to support them. They've done their part. This isn't a waste of money for them. We owe this to them. But we have to figure out a cost-effective way to do it. And it means it can't be arbitrary. We can't say, well, we're just not going to do this. It needs to be looked at in terms of the best potential for the greatest number of people and for what we would all want for quality of life at that particular point in our lives. So that's kind of how I look at it.
Commissioner Shapiro.
So how do we convince the woman who weighs 500 pounds to not weigh 500 pounds so that we could get the ramp?
She wanted that. That was the whole point. She wanted to get out and get the surgery, and the problem was because she didn't have the ramp, that she couldn't get out. They'd done the education. They'd sent an educator in. They had worked with her. She was ready. But for the rehab and everything that would need to go on to make this better for her. And she had a glandular problem as well as the eating problem.
But I guess my question is, along with all the other integrated components of this system that you're talking about, one of them, I would assume, is education for the individual. And I'm wondering if you were in charge of the world, and I'm all for it, by the way, after your presentation. I'd like you to be in charge of the world.
I'm like that other guy. I wouldn't be in charge of IHSS. I'd be in charge.
Nobody wants that job. Nobody
time.
wants that job. Yeah. But maybe you could speak briefly about what role education
I think
would
that's
play.
a very good question. It's an excellent question. CDC came out with a study, and I'm sorry I didn't bring the statistics, but in that, and we've been talking about this for forever, in that study it showed that people who were physically disabled, in wheelchairs, walkers, obese, but had a physical disability, were a higher rate of smoking than the general population, in a higher rate of obesity than the general population, and on a higher rate of high blood pressure than the general population. Done by CDC. The chart has a little white and a little black and scale, and that line was in some cases significant. One of the things we've found about health professionals is that when they're like us, human beings with their own biases and ideas, and so we want to train them. Because what they do is they see somebody in a wheelchair and they say things like, well, if I were like you, I'd smoke too. Instead of thinking about we've got to do prevention for folks, and we can't skip any part of that review that we do, of that history that we do, including sexual activity, including marriage status, because don't assume you're neuter because you're disabled, because it just isn't true. They skip things because they think if you're disabled, they only see the disability, not the person. So we're really pushing not only primary prevention, which we think is absolute. You can exercise in a wheelchair. There's accessible exercise equipment. There's also exercises you can do that are free. You can use freestanding with your arms and shoulders. There are people who know that. So we believe that education for responsibility, that lady who thinks that she ought to, have somebody come and clean her house because she's going to work in a nonprofit, well, we just have to send over somebody to help her, show her how to do shortcut cleaning, as far as we're concerned. Because unless she's physically disabled to the point that she cannot physically do the task, there's no reason that she can't. I believe that I have a responsibility for my health care, for my transportation, for my employment, and that everybody else needs that. But part of the problem that we run into in education is we teach disabled people, especially from childhood, that they're helpless and we need to take care of them. And that we treat them like children, and then they don't get the rewards of adulthood. I don't care what the disability is. I had a doctor tell my mother I would be dependent for my entire life and they would have to take care of me. I do not see what my eyeballs have to do with my brain. Never have. But the doctor said that. So part of this is educating the health providers themselves, the social workers themselves, not to assume. And the other part is to say to the people, you have responsibilities. And these responsibilities include demanding the print be big enough so you can follow the instructions you need to follow to do what you need to do to comply with this care. So for me, education is a two-pronged. It's for the providers who don't follow normal protocols on primary and secondary prevention. It's on gathering data about secondary conditions such as bladder infections and spinal cord injury because we give them catheters. We don't give them enough catheters, or because we don't give them the right care. Kidney x-rays for spinal cord injury because replacing a kidney is a lot more expensive than doing the x-ray. And educating the person with a disability to know about what they need to do about their condition, such as diabetes, obesity, high blood pressure, and also to know what, and if it's their family that's doing it, then the family needs that education. So I'm very much on the same page as you are. Part of the cost is people have told me I don't have to be responsible for myself. Well, I don't believe them, but there are a lot of folks who have bought into that. Now, if we were women in the 18th century, well, we would have been, kind of helpless, and men would have done it all. It's that same kind of attitude. So we have to eliminate that and say to folks, you're responsible, and we're going to hold you responsible. And if you can't comply with certain things, then we're not going to be able to do things for you. And a lot of the folks that you hear who come in, who might say things in offices, and when I sit back and hear them, I will say, you may not be able to. That's your job. That's not their job. So that's a lot about education, I think.
Any other questions? Thank you for your very...
Eloise, you're not going to ask. I'm so disappointed.
You did a good job. Why would you want me to mess it up?
Thank you for your very eloquent testimony.
Thank you very much.
Do we have any public?
I'm not in charge of that, so I don't have any cards. I don't have any cards from the public, so I will adjourn the public hearing. We'll convene our business meeting in about 15 minutes over at the 925L in the basement.
Visit my friend. I'll see you.
All right.
Okay.